Thank you. Hello, everyone, and welcome to our training today, Turning Data into Information. This training is the second in a series of webinars offered through the end of 2025 by us, Illinois Public Health Institute, IPHI, through the funding of IDPH and the Community Health Assessment and Planning Grant to support the IPLAN. This is a series of 2 out of 5, and this session will be recorded so folks can see it on the IPLAN website in the future. Thank you all for joining us here today. Jumping right in, my name is Samantha Lasky. I use she, her pronouns, and I'm a program manager at Illinois Public Health Institute. I am joined by a few colleagues here today, Kaden Aguirre, who is our senior program manager, and Mediha, who will be here supporting with any technical assistance needs. Feel free to message us in the chat if you have any issues. And we have two lovely presenters joining us today, Aldara from Southern Illinois University and the St. Clair County Health Department, and Sarah Kelly from the University of Illinois. And they will be giving us 2 presentations in the first half of this hour today. Today's agenda will be focused on starting off sharing the importance of data for community health assessment and community health improvement planning. We'll talk a little bit about data analysis and data-driven action planning through our presentations with Aldara and Sarah today. We'll have a short break at the top of the second hour for about 10 minutes and come back. And then we'll talk about data visualization storytelling, have some time for some questions and answers, and then do our closing. In the first hour, you'll hear from our peer presenters, and we'll be doing some polls. So we ask that you actively participate if possible. I know that can be difficult sometimes because we're remote, or this is a Zoom poll, or this is Zoom. And then in the second half, we'll have a breakout group and have some group discussions. So if you are able to stop multitasking, feel free. As far as the learning objectives, we think you'll be able to better understand to use data to define health issues and understand the causes of health inequities through data, both qualitative and quantitative for storytelling, and sharing assessment information with your community, and hopefully be able to use data to better inform actionable strategies to address your IPLAN priorities through storytelling and narrative building. So this is what we're hoping to accomplish today. Though there might be some of us who have joined these trainings in the past, some of us who may be newer, but these are our typical group agreements that we generally use to create a conducive environment for learning. Please let us know if there are any concerns or questions about these. We are not the end-all be-all experts of this space. And if there are any questions that we have and we might not be able to address, we'll make sure to note them and get back to you from who can address them. We also know there's plenty of expertise in this room. So feel free to respond to other people's questions and have an open discussion if you feel like you can answer them. We want this space to be where we learn from each other, not just a one-way street here. And the Q&A button feature is enabled at the bottom too, so feel free to use that as well. Okay, starting off, we would like to hear from you. We would like to know, what does turning data into information mean to you? So we're going to share a poll now, and we'll give everyone a minute to respond to that poll. Awesome. And if you can't see it, feel free to also drop any responses in the chat. So take a minute, and what does it mean to you to turn data into information? Seems like a few folks are just joining us. This is just an introductory question for folks who are joining. the poll, we are asking, what does it mean to you to turn data into information? If you can't see the poll, you can feel free to drop your response in the chat as well. We'll be monitoring that too. We'll give it another couple seconds. Okay, great. Looks like we're getting some more responses. I think we can go ahead and close that poll now. And feel free again to drop responses in the chat. So what we're hearing about from folks here today, it means to be actionable for policy and activities, to better understand health trends and behaviors, conducting data analysis and interpreting for better decision making, supporting initiatives and goals, into understandable, usable information, a lot of guide decision making, actionable initiatives for improvement. Translating data into easily understandable and readable information in a manner that is most useful for the target audience, for sure. These are really great responses. Appreciate you all taking the time to respond. This is great for grounding us and what turning data into information means for us and how we'll go through the day together. So thank you so much for that. Okay, diving right into discussing the importance of data. Why is data important? Why do we need to capture and share information in our assessments? Well, data helps us to paint a full picture of the health of our community and what's going on in it. It helps us to understand the health of our community at large, as well as the health of the subpopulations within our community, especially those populations that are disproportionately impacted by health disparities. And it also the data helps us identify priorities and to develop and implement actionable strategies for health improvement. It is the community health assessment and leads the community health improvement plan. Data also helps us understand the inequities in our communities and why they exist. They uncover the root causes that influence health to provide necessary context to what's going on in our communities. And without it, we have an incomplete picture of the community, and that prevents us from strategic action. On the right here, this health equity, which I love that, whoever picked that name, lovely name, by the Massachusetts Community Health and Healthy Aging Fund, illustrates this understanding. So you can see from the top down, we start with the leaves, and the leaves of the tree represent the health outcomes. This includes the physical and mental health of individuals and populations, and historically focuses on things like chronic disease, depression and behavior, injury, things of that nature. Then we go down the tree to the branches. The tree branches are the health behaviors. Health behaviors such as diet and exercise influence one's health, influence one's risk of poor health outcomes. While individuals can make lifestyle changes to improve their health, it's important to consider that the factors that influence their ability to engage, there are factors that influence their ability to engage in health behaviors. And those factors are this tree trunk. The tree trunk are the social determinants of health. These are factors that are certain conditions that influence people's ability to engage in health behaviors. I know a lot of us know social determinants of health. We hear that a lot. These are social determinants such as education, employment, housing, the conditions ultimately, and we hear this definition a lot, in which people live, learn, play, work, worship, and age. And they affect a wide range of health, the functioning, and the quality of life outcomes and risks. These can also include the built environment, the social environment, violence and trauma. And we'll share resources at the end, and that'll include the health tree that talks a lot more about the social determinants as well as the full version of this resource. Then we go further down, and we're getting underground now into the tree roots. These are the root causes of health. When we think about making lasting changes with the social determinants of health, we need to think about what created these conditions in the first place. What are the policies and systems involved? The tree graphic highlights some of these root causes, and they include racism, poverty, ageism, and structural and institutional barriers. And then finally, we get down to the soil. These are the underlying systems of dominant culture and narratives. They're represented in the soil in which the tree stands. The healthy soil means healthy roots, means a healthy trunk, branches, and leaves. And the dominant culture is the culture that has been able to, through economic, social, or political power, impose its values, its language, and its ways of behaving on other cultures. Like the soil surrounding the root system, things like white supremacy culture can often be nearly invisible given its position as normal. So these are important. This is important context of inequities when we're thinking about data and how we understand these health outcomes, which is oftentimes our priorities in our IPLANs, and how we can understand and dig deeper into the root causes and underlying systems. We'll talk a little bit later about dominant narratives and how we can begin to shift from dominant narratives to transformative narratives to combat our audiences and our community's existing worldviews. So we just wanted to share a little bit about that to ground us in this work, and then we'll move forward. Now, now that we've established why data is important for our work, let's talk about what's required in terms of data for IPLAN at FAB. So, in the substantial compliance checklist, we have a few things here. The substantial compliance checklist requires the description of data that is summarized and the information in which the priority is based. It includes the relationship of the priority to healthy people, national health objectives. It asks for analysis by grouping through the iQuery and the 7 data categories and the description of health problems most meaningful for the community by grouping. And we'll talk a little bit about these seven data categories in a second. And then it also asks us to include each strategy with an analysis of community resources that contribute estimated funding needed and anticipated sources of funding. So with our 7 data categories, these 7 data categories are required for secondary data. They are demographic and socioeconomic characteristics, general health and access to care, maternal and child health, chronic disease, infectious disease, environmental occupational injury control, and finally, sentinel events. And for some additional information, sentinel events, event data would be collected through iQuery typically and is defined as any unanticipated event resulting in death or serious physical or psychological injury that could have been prevented or managed by the healthcare system. So there are some and that was per the administrative code. And there are some examples that we'll share as well that you can reference in the iQuery website. Oh, sorry, I meant to drop that in the chat for everyone. Oh, my apologies, everyone. Why drop this in the chat for you all? Okay, thank you, Medea. Now let's talk about FAB. So there are a few more requirements. Most notable to point out is the emphasis on the examination of disparities between subpopulations or subgeographic areas and other local jurisdiction characteristics, a description of inequities and the factors that contribute to health challenges, which typically or must include social determinants and built environment. Data also must include both primary data, that is data that you collect, that is qualitative and quantitative. Other requirements include an ongoing non-surveillance population data collection. So this is participation in data sharing with other entities, analyzing public health data, sharing findings that include data visualization, and then using the data to make recommendations and inform actions. It's a lot for FAB there. For the CHIP, the emphasis is on reviewing the causes of disproportionate health risk or outcomes for specific populations, and you can see those here. And feel free to refer to FAB Standards and Measures version 2022 for more information. So we just wanted to briefly review that. Now, Very quickly going into data sources here. We wanted to ground ourselves in some definitions. So these definitions are pulled from FAB and they will be used and discussed throughout the entire training. And so we want to make sure that we are all together here and understanding the differences. So primary data is data collected by you, the health department, while secondary data is data collected by others and used by the health department. So a lot of secondary data that you will be getting will be from iQuery. Qualitative data is data that's most often open-ended and is not numerical, things that are difficult to measure, count, or express in numerical terms. While quantitative data is numerical, those can be counted, compared on a scale, things of that nature. It's important to note that with primary data, you can have both qualitative and quantitative data. And I think our presenters today, Aldara and Sarah, have some really great examples of what that could look like, and so do we later on in this training. So okay, I'm going to take a break from talking for a second and make this interactive again. So we're going to launch another poll here and ask you all a question. Have you accessed data from iQuery in the last 6 months? We just want to get a feel from folks to talk a little bit more about iQuery and data sources. Great. And we can go ahead and share those results. Thank you so much. Okay, so it looks like 77% of us said no, and this iQuery is relatively new. So that could be understandable. 20% of us said yes, that's awesome to hear, and 3% said unsure. If anybody has any questions in the meantime about iQuery, feel free to drop those in the chat and we will 100% um bring those back either at the end of the training or following this training. Great. Thank you so much, everyone. So let's talk a little bit about iQuery. So I don't want to get too deep into it because we have a whole technical assistance session that we did last year where you can learn a lot more about it. And we actually have a data session coming up at the end of April, but I did want to ground us a little bit in our new iQuery dashboard. So IDPH prefers that health departments access data from iQuery first per the local health department certification code. iQuery has been updated and can be accessed using an Illinois.gov account. To access the dashboard, local health departments need to connect to IDPH to sign a data use agreement. And we will drop the information in the chat on how to do that. And you can see it on this site on this slide as well, on who to contact. Thank you, Madiha. To be able to gain access to the new dashboard, you'll have to sign that data use agreement. Only one agreement is required per health department, and then multiple users will be able to access the iQuery dashboard. So this is a great resource. We had the opportunity to get an overview of it from Frida Folcom, who's on the call today, late last year. And we hope that more folks can get in contact with them, sign that use agreement, and be able to access the new iQuery. And any questions you have, feel free to put them in the chat regarding that. Now, these are some other common data sources, and you'll see these on the iQuery website as well, that folks often use for secondary data. So this can include BRFIS data, so that's the behavioral risk factor and surveillance survey, county health rankings, some CDC sites, US Census, things of that nature that you'll see here. And I think we have one more poll to ask, what additional data sources do you use to compile secondary data to find information with the 7 data categories that are required per the substantial compliance? We'll give everyone a moment to answer. Awesome. Okay, I think we can close now. Let's see what we got here. Champaign County Health Atlas, the CHNA, CDC Wonder, Burfus, Illinois Youth Survey, local organizations. That's awesome. Cook County Health Atlas, County Health Rankings, and the EPA for environmental. Those are some really good answers. Thank you all so much for sharing. Now, along with secondary data, we also have primary data collections. As I said, you use primary data to supplement secondary data. This data often helps us understand the health conditions we see in secondary data. It helps tell us why. It paints the full picture, and without both primary and secondary data, we will not have a full picture of what's going on in our communities. It can, according to FAB, it can be useful to understand the health issues of the population served, which may include the exploration of disparities or contributing factors or causes of health challenges. Collection of primary data does not need to be complicated or costly. It's intended to enhance knowledge and understanding of the population served by the health department. These data may address social conditions that have an impact on the health, for example, employment, poverty, lack of access, transportation, and health departments should really need to demonstrate capacity to collect primary data or ensure they have access to another entity that can collect primary data on their behalf. And these are some commonly used methods. As folks know, oftentimes we use focus groups or surveys, community forums, or interviews. These are some additional observation, asset mapping, photo voice are some really cool alternative methods that aren't typically used as often, but have a really great structure to be able to gain some good information from our community. And now we have one final poll question in this first half before I pass it over. This training is not intended to teach how to collect data, so we will not be focusing on the how-to for data collection. We'll be hearing and seeing from how primary data helps us tell the story of community health. We'll see several examples of data visualization and hear from some folks, from some fellow health department folks, to analyze and share their data. So we want to ask, what methods have you used to collect primary data? And let's see, we'll give it another second. Okay, I think we can go ahead and close. Wonderful. So it looks like surveys, most of us are definitely using surveys and focus groups and listening sessions. I love to see the folks who have used interviews and observations. And feel free to drop in the chat if there's one of these in here that we've never used before that you didn't see on this list that you'd like to share with with everyone. Oh, and we have a question about photo voice. I can share that very quickly before moving on. So photo voice is a structured process. It takes photos to determine strengths and assets and barriers of health or how community members define a health community or lack thereof. So it's essentially like kind of says it's a photo. Community members go out and take photos to really demonstrate what their health and their community looks like. There's more to it than that, but that's like a really broad, quick answer there. Great. So now I'm going to pass it on to Aldara Henderson, previously and still with actually the St. Clair County Health Department, as well as Southern Illinois University, to talk a little bit about her work. And so Aldara, I'll pass it over to you.
Awesome. Thank you so much. I'm really excited to be here. We have been so lucky with St. Clair County to have this wonderful partnership. We have two hospital systems and two health departments that we work collaboratively, to go through this whole process of analyzing data and helping to identify the priorities, within St. Clair County. Next slide. So as I mentioned, and Samantha, as you've mentioned previously, we create and collect this data because as epidemiologists, as working through IPLAN and all of that, we're storytellers. We're providing that data that provides the story. And when we're presenting this data, so whether it's with our Board of Health or our collaborative, our healthcare commission, which has anyone that touches the health of St. Clair County, our boots on the ground organizations, and, even within the community, we want to make sure that it's accessible. So we're painting the story of our community health principles, identifying that, making it simple and that it's understandable by anybody within the community. Next slide. Now, I really love the tree, Samantha, that you showed earlier. I'm thinking we might have to incorporate that on future presentations because it's amazing. But this is just another visualization of that. And so we incorporate that in our presentations, in our slideshows when we go through and we're sharing about our analysis that we've completed. Next slide. So again, when it comes to, there's just so much data out there. And I think that's the problem. We go into this completely overwhelmed. Like, where do we even start? And I know with iPlan, we have our 7 data categories. And I think it's important once you start going through that to kind of have those categories in place and then start kind of doing research using county health county health rankings. They have subcategories to help kind of guide you. And this is how we looked at our access to health and healthcare barriers. We looked at structural, financial, and personal barriers, for accessing health and healthcare. So part of that, this served along with those 7 data categories, this served as our framework for how we went through to collect our data. And the good thing is, and I like to look at this when you're collecting that secondary data, it's great because once you have it, it's easy every year to update it annually so you're not starting over completely. Yes, you might decide to do more research for your primary data, your surveys, and all showed something that maybe that secondary data dive didn't provide any insight on. And so but that you can add, and so it's good if once you have that primary data dive, that secondary list, just being able to update it annually, which is what we do here in St. Clair County. We do an annual review of all our data points that we've collected, and then we also do an annual survey to the community. And so our community survey, so that's our primary data that we're collecting, and that includes both quantitative and qualitative data. So that includes open-ended questions that people can freely express how they feel, what could better the health of their community. And so most of the time we get really good feedback from it. Sometimes we get some interesting things, like someone didn't like the Christmas decorations in our town. But once you sift through all that, next slide. So what we did with our partnership is our different subcategories. So I'm going to briefly go through them because we had a 52 slide presentation with all our data. So it would be overwhelming and we would be here for an hour. But we looked at our county demographics. Next slide. And here's a table. We look at Illinois, we look at St. Clair, within the years, and we look at the percentage change. So you don't have to be an epidemiologist as you go through your data to see things that might stick out to you. When you compare your county versus the state or versus national numbers, you may see things that pop out are this might be a priority within our community. Next slide, please. Then we looked at poverty and housing. So we looked at all of these different data points in this. And it's really interesting, some of these data points, we as a health department, or I didn't have access to it, but because of our collaborations with the hospital systems, they had some data and they provided us that data. And it was really interesting to do that. And also, if your health department doesn't have an epidemiologist, but you partner with hospitals or even within your own health department, you might have an intern who really loves data analysis. And that would be a great thing to incorporate. Or you might have somebody within your health department that has background in research and data analysis. Next slide. So we want to make sure that everything is clear, visually clear and easy to understand when you're creating these graphs. So this is a really good kind of one look at the race ethnicity of St. Clair County. Next slide. I like heat maps. We all like heat maps in our county. So this is wonderful. And what's really good with county health rankings, the website, they have these wonderful heat maps that you can look at and add to your presentation. So it helps to visualize, when you're looking at that, you can immediately see, oh, this is where there's an issue. So heat maps or just health graphs really, really do help with expressing your data. Next slide. Again, I know Samantha will talk about, graph accessibilities and everything, but again, you want your graphs to be clear, easy to understand. And for us, we like to compare St. Clair County to the Illinois percentages. And even within this line graph, we have different shapes. So if somebody's colorblind, they can see the differences between the lines and understand with the key on the bottom. Next slide. Again, we look at education attainment, employment, unemployment, computer access. Next slide. And we try, again, with our graphs, very clear, very simple, and comparing it to the state. Because even if you're not doing in-depth data analysis, you can see, where there is a large difference between, your county and the state on the whole. Next slide. Again, more tables and things, just showing unemployment, it's just, these are just some of the examples of the data we collected. So our secondary data. Next slide. And here we go into food insecurity, etc. Next slide. And then we kind of focused on food insecurity, with some of our graphs, with some of our data. Next slide. Again, this is just some of the samples of our visualization. So what we ended up doing, I believe that's the last slide, correct? There might be one more. And this was actually in the next slide. Just go into the next, sorry. This is really good slide because it shows the information we got from our emergency department. So with our partnership and our collaboration with the hospitals, we were able to get some of this information for our emergency departments. And is that the last one? Yeah. Oh, okay. So when we did our deep dive, we came up with these priorities that were highlighted. We saw some access to behavioral health services, healthy lifestyle. So these kind of rose to the top where it was significantly different and higher and showing some sort of issues within the state compared to the state. So going through all our data, is, looking at this and that highlighted. And so when we took these priorities, we presented this because we were we felt being transparent with all of our partners, with everybody involved, to have all of these priorities out there, the data that supported that. And then we moved on to doing our primary data collection. So that's when we did our community health, our health survey. And we're actually about to release that here on April 1st, our next round of our survey, to see if anything has changed, any of our priorities have changed. So like I said, you don't need to do in-depth analysis, but if you create enough data points from it, you're able to see and highlight those differences, highlight many issues that are within your county, and then you can go and further investigate that through your community survey when you're going out there and having open-ended questions and then creating, maps and identifying. And we identified in our own primary data, our own community survey, just number of people who went to food banks, and that we did it by zip code. And we were able to say, okay, these are the areas we need to look at or possibly get more information from. So I think that's it.
Great. Thank you so much, Aldara. Does anyone have any questions for her? We had one come in the chat while you were chatting. One came in the chat about survey fatigue, how that is managed when you send out a yearly survey to the community.
So that's really, yes, and that's something that we actually recently discussed because just the number of surveys. So because we have that partnership between the hospitals and the other health departments, we're minimizing at least 3 surveys there that you would normally get. And if any of our partners have specific questions that they want to ask, we can include that into our large community health survey. But it helps us with our collaborative because we're not having the hospitals release their surveys, and all of that. It's just one survey across the board. So that helps. And to do it just annually, it helps from constantly being surveyed. But as epidemiologists, we want to go back and compare previous data and track trends. And so having that annual data helps us do that. And with all our systems on different reporting cycles, having, where it's every 5 years for us and our hospitals every 3 years, having 3 to 5 years of survey data, that's going to just make it easier for everyone. And knock on wood, in case there's another pandemic, we have that data that we can use for our IPLAN, for our FAB accreditation, and for the hospitals.
Great. Thank you so much, Aldara. If anybody has any other questions for her in the meantime, feel free to drop them in the chat and we'll come back to them. We're going to move now to our presentation from Sarah Kelly. Thank you so much again, Aldara. If anybody feels like they need a quick stretch, feel free to raise your arms up in the sky and come back down, and I'll pass it over to Sarah. Sarah has supported Tri-County in Tazewell, Peoria, and Woodford in their work and their partnership. And we're really excited to have her here today as well. So I will pass it over to Sarah.
Thank you. Good afternoon, everyone. I'm excited to be here. I am an assistant professor at the Illinois College of Medicine in Peoria. So with my PhD in EPI, I have the privilege of leading the data team within our Partnership for Healthy Communities, which is similar to our previous speaker, Aldara. We have a partnership that has been really helpful to get things done in the Tri-County region. In my role with the partnership, I focus on leveraging various data sources, so quantitative and qualitative, to identify and address community health issues and needs. So today I'm going to talk about, how we integrate both of them to provide a comprehensive insights into community health. Next slide. So before we dive into the details, I'm going to give you an overview of what I'll cover. So I'm going to start out with some background on the partnership, the importance of quantitative data, which has also been kind of talked about, population health assessments that we've specifically used and how we do them, and go over the practical application, kind of go through an example. And then also provide like a summary slide that has helpful resources that I will reference and tell people to use and kind of go to. So next slide. Okay, so Partnership for Healthy Community is a partnership of representatives from Peoria, Tazewell, and Woodford counties. We have 2 healthcare systems, and we have medical school, we have nonprofit and for-profit organizations, so various entities that come to play. And within that, we have a data team where we formed a data team. And the goal of what we do in the data team is to really track progress and challenges within the Tri-County region and provide timely feedback to the communities, but also to the board of the partnership on a variety of health metrics. So we We have quarterly data reports where we combine different outputs from the interventions that have been selected from the CHIP. And we also have outcomes that are related to the priority areas, in addition to a very long appendix that has like just a constant updating, of public health surveillance using external data sources and whatnot. In addition to these quarterly data reports, we have annual data reports where we update mortality and public health surveillance measures, just because we know that a lot of these only update once a year, and they unfortunately are a little lagged. So, there is that, but we try and have this, we do this every year for our community. Next slide. All right, so next I'm going to introduce MAP 2.0. I don't know how many of you have heard about this or are using it as well. It's a community-driven strategic planning framework developed by NACCHO. MAP 2.0 stands for Mobilizing for Action Through Planning and Partnerships. This framework's really designed to achieve health equity and assess pressing population health issues and align resources across sectors for strategic action. And it builds upon its predecessor MAP, which I know some people, some places are still using that, but it really emphasizes the importance of community engagement, data-driven assessments, in particular 3 assessments, and focus on health equity. So it provides a structure for communities to kind of assess the health issues, align the resources, and have strategic action. So as you can see on the picture on the left, the framework is really streamlined into 3 phases. The first phase is to build the community health improvement foundation, where you establish strategic relationships, conduct a starting point assessment, and develop a shared mission and vision. And then the second phase, what I'm going to talk the most about today, is phase 2, where we tell the community story through a series of 3 specific assessments or primary data collection. So we have the community partner assessment, and that really is a survey that identifies the capacity of our organizations, which is a total of 18 organizations that are part of our partnership. And then we have the community status assessment, sometimes referred to as the CHNA, Community Health Needs Assessment, or CHA. In this process, it's called the CSA, because we really do love acronyms in public health. And then the community context assessment is the qualitative data. So that's where we go and kind of find out more depth about what we find in the community status assessment and what other sources that we're, issues that we're seeing. And then the third phase is continuously improve the community, where we implement and refine the strategies through continuous quality improvement and rapid cycle testing. By following this framework, we have really can help create sustainable and equitable solutions for well-being using mixed methods assessments, which have been really helpful. And then the figure on the right, or picture on the right, is I'm going to come back to, but it kind of shows how it's actually done with MAP 2.0 and how you use those CPA, CSA, CCA, those data assessments, and how you go across, and from those, you use these cross-cutting themes that we've talked about previously today, to how social determinants of health, systems of power, privilege, and oppression, and these different health outcomes impact our overall health and well-being. So using those cross-cutting themes, we then develop issue statements or priorities for our community. Next slide. So for these community assessments, I'm not going to drive too much into this, but there are, the following categories are typically used, which have been mentioned previously. And really, data, we do this because we know that data plays a crucial role in public health and what we do. We have a better understanding of what's emerging, how we can inform policy and decision making, how to evaluate public health interventions and support health equity, and to also prepare for public health emergencies. Next slide. And a lot of this starts with providing context, which I know Aldara, our previous speaker, talked about too, is really understanding and comparing to Illinois, and comparing to the US as well. So I think as like a first step, a lot of the time, and what I've done with when we've compared data is first look at Illinois and where we are, because we know a lot of policies and culture and pieces are similar. Based on where you live. And so some of the top strengths in Illinois, we have low prevalence of adverse childhood experiences compared to the other states in the US. Drinking water violations, lower prevalence of that, and frequent mental distress is lower. Water fluoridation is lower, and physical inactivity. Our challenges in Illinois: racial disparity associated with premature death, housing with lead risk, excessive drinking, homicide, and residential segregation among Black and white residents. So, next slide. So to drill down to this, an example of what we did in assessing these issues in comparison to Peoria and the Tri-County region. So I'm going to go over Peoria specific. A lot of what we do, just because we have 3 counties, is look overall and then look by county too, because there are differences in those different demographics. Sometimes and sometimes not, but usually there are more differences just given the demographic profile. So in regards to mortality, our youth mortality rates are, are of concern. And this is something that, just based on the previous slide, we know is an issue in Illinois, right? Black youth die at nearly 3 times the rate of white youth. And in Peoria, it's worse. The gap is wider. So Black youth die at nearly 4 times the rate of white youth in Peoria. Next slide. In addition to this, one of the other things that we've pulled and we've been tracking is suicide mortality rate, and we've identified disparities and rising gaps there, specifically among the Black population. You can see here, while the mortality rate is higher for the white population, the rate of suicide mortality is increasing at a faster pace for the Black population. And we know that there are some risk factors that for suicide, right? Geographic variations, Rocky Mountains have higher prevalence. But we also know that economic stress, poverty, mental health conditions play a big role in these as well. Next slide. And so to kind of take a step back and use things. So this is from County Health Rankings, which I really like. I think that's one of the easiest sites to kind of use to get an overall picture of where your county stands. So for Peoria County, when it comes to health outcomes and health factors, we are, about the same as average in Illinois, and slightly better than average in the nation for outcomes. And we're about the same as average for health factors. Next slide. So that doesn't necessarily mean that we're about average for everything, right? Like we have some emerging issues, and within that we have seen that Peoria is getting worse for sexually transmitted infections. In particular, chlamydia rates are of concern. Children living in poverty is something that has come to light as an issue. 18% of children in Peoria live in poverty, which is higher than Illinois and the US. Next slide. Okay, so I'm going to talk a little bit about how we did the CSA, and while we did it, and kind of reviewing the results of that as well. So in general, like, when we had the community status assessment, we proactively, the data team, continued to inform like the partnerships, the 18 different organizations that were working with community partners to kind of get the survey filled out, which can be difficult at times just because of survey fatigue. We do ours every 3 years, but even then it can be a little difficult. And there was a need to they really wanted to see regional differences, and to do that statistically, we knew we needed a certain sample size. So we really wanted to help inform efforts so that we got the population and we could have better generalizability for our regions. Next slide. So we provided weekly updates for the CSA as it was being pushed out. And so statistically, to have like a 5% margin of error, 90% confidence interval, to understand and identify regional differences. Within each county, we had a certain set of regions, and we kind of just weekly said, okay, this is how we're doing. You've met your goal, you haven't met your goal. So when you go out, can we really need to have surveys filled out in region 4, 5, 6, or, so on and so forth. Woodford County did excellent. I mean, they're less populated, so they really they have more of an uphill battle, and they really knocked it out of the park. Next slide. In addition to overall number per region, based on the survey results weekly, we also looked at demographic profiles of these individuals for each county, to really kind of help inform the efforts as well. So does this look like the census population? Okay, do we need more males, females, X, Y, so that we can inform and try and work on getting those individuals to fill out the survey, just to have a more representative sample. Next slide. So this was the overall response rate. Woodford County did really well. Yeah, we were really happy with what we had. Next slide. And one of the ways we visualize this or kind of talked about it is we compared again the overall results once we were done collecting the survey. So the response percentage to the census percentage. For gender, we had more female respondents, which is not uncommon. That was like previous years. And it's not uncommon in research either. But looked at income, so approximately half the respondents reported living below the median income, so we're pretty happy with that. We did have a slightly higher response rate for the white population, but there weren't substantial differences, so we were really happy about that. And we think these weekly dives and investigations really helped inform outreach efforts. Next slide. So one of the other things we did is, this is based on one of the questions where we asked the perceived what the biggest health issues are in the county, or where they live, and they were able to pick 3. So the top 3 across the board were aging issues, obesity, and sexually transmitted infections. We broke it down by county as well. Next slide. So with this, we not only looked at what the top issues were, which you can see here with 1, 2, 3 and the stars, but also identified if there were counties that had significantly higher responses for a certain outcome. Uh-oh.
Don't know what happened there. Let me fix that. My apologies.
No worries.
Okay.
Here we go. Next, you can go to the next slide.
Okay. Sorry, everyone.
No worries. And kind of like I said too, so Woodford County is considered, a lot of it is considered rural by HRSA standards, in comparison to Peoria. But we do have parts of Peoria that are rural. So one of the things that I did was among the Tri-County residents, using their zip codes, just identified rural versus non-rural. And to identify if there are any differences as well, because we know that something like healthcare access is going to mean something different for somebody living in a rural area versus someone that's living in closer to Peoria or in Peoria City, right? Next slide. One of the other things we did was identified vulnerability. So we made an indicator variable based on a series of questions that were asked within the survey. so that we could understand for those populations that had higher vulnerability, what issues were impacting them the most and what, things, what factors and other circumstances attribute to this. So vulnerability was assessed based on income. So those who reported less than $20,000 a year, those who were minorities, LGBTQ+, and those who said they were uninsured. Next slide. So in addition to looking at the different health outcomes, we looked at overall like vulnerability, how many of our respondents had at least one indicator of vulnerability, which is about 30%. And then like 2 or more vulnerabilities was about 9%. More of those, the vulnerable populations lived in Peoria. So this we use to kind of understand where those marginalized populations were, what issues were impacting them. And then we broke it down by specific type, just because there's such variation between those groups too. So we didn't want to just look within the group. So next slide. So really this whole process and what we really strive to do is just continuous improvement. And so based on data collected from the CSA, we work directly with the community conversation team, which collected the CCA, the qualitative data, right? So we provided tailored reports based on who they were going to have focus groups with. And then we had we identified gaps and maybe where we needed additional voices heard based on who completed the survey and who didn't, and then where we were seeing differences, significant differences. This really helped provide context and depth on what the health issues were in the region, which is really helpful in understanding how we can identify interventions that are going to be helpful. Okay, next slide. So the results from the CSA, the CPA, and CCA all are going in to help with the prioritization process and identifying these issue statements. Board and community members are presented with the results from all of these different assessments, and a series of meetings to review and discuss the findings are happening. And that's where they're going through these cross-cutting themes to really understand the health issues and priorities in the area. And that's where the 10 the issue statements will come out and then be voted on for prioritization for the next cycle. Next slide. So these are kind of the most commonly used resources that are free and easily available. Essence, it should be available at the county level. Health departments, the epidemiologists typically have access to these, but all the other ones you can get, you don't have to have like specific county health department information to obtain them, besides iQuery. But a lot of them kind of help guide and provide insight into what the health, issues are, and in relation to Illinois and the U.S. And really, in addition to these like public health surveillance tools, partnership has been one of the biggest helpful resources, I think, and just working together and leveraging that partnership, because we've been able to collect and get external data like from our community dispatch and from our school systems to understand things like youth mental health or suicide calls and whatnot too. So our data reports went from like 25 pages to over 60 pages, just because we've continued to have people come to the table to kind of work together and understand the health issues in the area, which has been really nice. So I think that's it. Yeah, if anyone has any questions, let me know.
Great. Thank you so much, Sarah. Does anyone have any questions for Sarah? And feel free to drop them in the chat as well, or come off mute if you'd like.
I have a question, if that's okay.
Of course.
Oh, perfect. So I'm a little bit newer to facilitating the whole IPLAN process, and we're going to be using MAP 2.0 as well. And so my question is I'm thinking about my team and who I need involved in this process with me. As far as the data triangulation after we do all of our assessments, is that something that general staff would be able to do, or do you think that we would need, or do you recommend that we have somebody at like an epidemiologist level be involved with doing that work?
I think it would be good to have an epi involved, but I think in my opinion, and kind of the route we've gone is like the data team kind of summarizes the data. They have access to raw data, but they summarize it in 20, 30. The CSA is like 170 pages, but like the other portions, they're kind of summarized. And then as a team, like the board comes together and meets and talks about the results as well. But the data team and the epi would be really helpful in kind of highlighting and making sure to use like the specific method so that you look at like the size and scope of the issue and identifying those emerging trends, or is it just is this what it's been for 10 years, or is this increasing, decreasing? So hopefully that's helpful, but yeah, we're definitely doing more discussion on it and going back to the community and talking about the health issues and the voting process and of those issue statements.
That is helpful. Thank you so much.
Yeah,
Thanks, Sarah.
that's exciting to hear you're using MAP 2.0.
Me too. Yeah. And we actually have a training that we gave last year, a little less than a year ago on MAP 2.0 last summer. If anybody's interested in reviewing that, that'll be posted to the iPLAN website. And especially with the data triangulation, I love the part that Sarah was noting specifically about going back to the community. That's a big part of it as well. And a big part of MAP 2.0 is recognizing like what resources do you already have that exist to help you do that part. So any other questions? Right. Well, thank you so much. If you have any other questions for Sarah or Aldara, feel free to drop them in the chat. We can either answer them at the end, or we can send out a oh, thank you. Joanne posted the trainings for 2024 in the chat. Or we can send an email out with our follow-up with more information from Sarah Aldara as well. So thank you both so much. Now we're going into a 10-minute break. Please don't log out. Feel free to step away, minimize, but don't log out. It's easier to just stay here and come back in 10 minutes. We will be coming back at 3:10. We'll be doing a lot of conversational discussion, breakout group kind of stuff when we come back. So be ready for that. And we will see you in 10 minutes. Thank you so much, everyone. And I'll put a countdown on the clock. So with data
Recording in progress.
Thank you so much, Madiha. With data visualization, Data visualization summarizes the important and interesting research findings. It identifies patterns, enhances comprehension, and broadens communication for the key points and takeaways that you want to share with your communities and partners. The latter points are particularly useful when considering the social and political implications of your assessment. Data visualization, traditional methods are of communicating. Why data visualization? Because traditional methods of communicating are often of communicating. Sorry, let me rephrase that. Sometimes traditional methods of communicating research or assessments are often behind a paywall. They're published research articles or conference presentations, media outlets that might not be accessible for everybody. So when you are sharing the information that you developed in your assessment, you're not giving the full public the ability to understand the story. Additionally, jargon and technical language is not understandable to audiences who don't specialize in any type of the work that we do. And then as a result, it's not enticing for them to read. So data visualization cuts through all of those barriers to ensure accessibility to what's going on in the community to everyone in the community. It should be easy to understand, not take too long to get to the point, ensures retention, communicates stories, and evokes emotional reactions better than text would. So that's the importance of data visualization. Now, there's from the importance to the principles. There are some visual perception principles that are not always in the forethoughts of our mind when we're creating charts and graphs, especially since something we just got to do quick, but they're essential to showcasing data effectively, especially to those who don't have expertise in interpreting data. Many use Gestalt principles, and you saw a lot of those in the slides from Aldara and Sarah. And I'll describe these principles here to ensure that data visualization meets those fundamentals I noted in the last slide. It shouldn't take more than 1 minute for somebody, especially if they don't have the expertise, to understand what you're trying to show them with data. The concept behind some of these principles, like similarity, connection, proximity, and enclosure, is grouping. We tend to perceive objects that look alike are placed together, connected by lines, or enclosed in a common space. So kind of going through these different principles. And these are some of many Gestalt principles, but these are the ones that are very frequently noted. So starting with connection's pretty self-explanatory. On the left, you see 4 dots of the same size and color, and you recognize them as similar. However, when you connect 2 of those dots, your brain recognizes pretty quickly that those 2 have a special connection. So that's connection. That one's pretty easy. Proximity are grouping items, that's on the left there. Grouping items closer together when they're related, similar in color or size, also helps draw attention that these items are related rather than separate. It's helpful when we want someone to better understand a scatter plot, especially. Similarity is also pretty self-explanatory. We can make visualizations easier for users to understand what we're trying to show them with similarity, like consistency in color or shape. If we match the labels to the color used for the data, the user can interpret the visual better. So both Sarah and Aldara had really great examples of charts where the one line had circles and in one color, and triangles in another, and squares in another. And those are also accessibility principles. And we'll go through some of that accessibility later on as well. Enclosure or common region, which is below it, helps us identify items that are enclosed in the same region from as a similar group to show that they're separate from the others, or that you'd like them to stand apart. So that's like showing all of these dots on the left here. And when you simply add that box, you're showing that these are either separate or that they're standing apart from the all 6, 8, 12 box dots that you were showing originally. And then we get to continuity. Continuity is something that you see a lot more in visual text and things like that. And so this is a great example. You've probably seen ads more than once where you're reading and the human brain and the human eye follows paths, lines, and curves of a design and prefers to see a continuous flow of visual elements rather than separated objects. So you've seen ads before, and this is a good example. You want to read left to right and then under. And sometimes people change the coloring or the wording to make it look visually cool, but then that's not how people are reading it. So, for example, on the left here, we have Illinois Health Public Institute is how most people would read that, despite the fact that the colors are Illinois Public Health Institute from top to bottom. On the right, you see Illinois Public Health Institute. And so it's a lot easier to read the one on the right than follow what you're trying to follow on the left. So sometimes when you're doing visual design, you're wanting something to look fancy, and then that continuity messes with your ability to read the human eye to follow that correctly. And then finally, blank space. So this one might look a little weird with the graphic, but space is an element that highlights contrast. So consider using blank space in lieu of bolding, highlighting, arrows, or something like that. They're noise compared to what blank space can do. Blank space doesn't just have to be white space, it's just space. When I tell you to spot a yellow balloon on the photo on the left, your eyes move all over. And you start to even question whether there are yellow balloons or are they orange? Are we seeing different colors? While the second image is really clear. How does blank space work in a table? Maybe you can see that maybe thicker borders or additional colors might be completely unnecessary because it's taking away from the point that you're trying to make. So simply removing unnecessary lines or ticks or colors or boxes really creates a blank space that allows the user to focus on the data itself. So this is a really high level of some Gestalt principles that are frequently used and can be really helpful when you're trying to have good data visualization. So let's look at an example of how Gestalt principles are used to improve data visualization. This chart is supposed to be showing data from 3 neighborhoods over the course of 4 years. The data itself is not that important, it's just how it looks visually. Using Gestalt principles, how is space being poorly utilized in this chart? So take a second, feel free to unmute or put in the chat, how is space being poorly utilized in this chart? I'll give everyone a second. Awesome. I'm seeing in the chat from Selmeka Sarah. There could be lines to connect the dots. Any other thoughts? It's hard to measure over distance. Yep. What are some challenges that you're trying to read this graph? What is stopping you from being able to understand? The colors, all dots don't need to be blue, less grid lines. Yeah, all really good thoughts. The colors again. Yeah. So with this graph, as we're looking at right now, and based on what folks are putting in the chat, how space in particular is poorly used. Yep, another great answer, Chloe. The grid lines are distracting, so the data looks disjointed. So the minor axis lines and the boxing make it harder to read. The external boxes are also unnecessary. So the green does not contrast very well, and these tiny minor axis lines are completely unnecessary to be able to see what we want to see. So let's get rid of those. Now that we've fixed the blank space, and thanks for all the chats, Stacy, everyone, the colors, Christina and Patrick, these are really great answers. Now that we've fixed the blank space problem, how do we ensure connection and similarity? So again, connection, somebody already basically said this, so maybe they'll say it again. And similarity, how do we ensure that similarity is not a problem? What is still, or maybe I'll ask it this way, what is still missing from this graph to distinguish these different data points? Lines, Christina, yep. Change the shades from Amy. Lines and dot colors, yes, awesome. And I know Sarah at the beginning said lines to connect as well. Yeah, exactly. The color charting does not contrast well with the plot points. The colors are too similar and hard to distinguish. One tip is that experts typically recommend that you don't use the same similar colors like this because they're hard to differentiate, especially if you do have an issue visualizing color to begin with. But you also don't want to use too much color, so experts typically recommend a maximum of 5 to 8 colors, depending on how in depth your charts and tables are. And the lines between the data points do not show connection from year to year to follow the path better. So now we've changed that. Awesome. And then finally, so this is getting a lot more readable. We can probably all agree that this is a lot more understandable. The lines and the colors are distinguished. You can see from year to year. What do we want to do if we want to highlight what's going on in the year 2022, where all the neighbors were in the year 2022? This is when we use enclosure. So we use enclosure to share this. That's the box that's highlighting to be able to say, okay, we want to highlight this particular piece, and it helps draw attention. So if you're doing data visualization, you're trying to tell a story to your community, this is a great way to say, hey, we're talking about this specific instance and something. So this chart represents many of the principles. Continuity, because the points start and end in the same place. As you can see, everything is in order, and there's no question which points match up on the axis lines. Blank space, because all unnecessary lines and borders that draw attention away from the data are gone. Similarity, because the colors describe the relationship between the different points across time. So neighborhood B has the same color and they have the same shape, neighborhood A and neighborhood C as well. Connection, because the lines connect across different points to easily follow the difference from one year to another in the same series. Enclosure, because it draws attention to the specific part of the chart you want somebody to pay closer attention to. And all of these things, the best part about all this is that there's no fancy applications or anything that is need to be done to create this. All of these things are completely customizable and editable in PowerPoint alone. So I was able to make this chart just in PowerPoint. So that's one example of how data visualization looks in charts. Now, how does visualization look in tables? So in tables, and thank you all for participating in that. That was awesome to get your feedback. In tables, you can see that the table on the top has really thick borders, a lot of highlighting, and it really distracts from the data itself because your brain doesn't immediately search. It's too much happening at the same time. The bottom tables, especially the table on the bottom left, has lighter and minimal borders to allow the data to shine, and blank space is what's making that happen. Enclosure is also working here by highlighting any specific table lines that are most important to pay attention to. So that's like if we want to show group 3 and what's going on with them. And then ensuring continuity in a table is easier in a table, but it's still important to ensure that you're doing accurately so it's read right. So this is some examples of how Gestalt principles are used in tables. This bottom right table looks nice, but there's no guidance for your eye to follow with continuity. The blank space is a problem. And the table on the bottom left shows some better principles to highlight how blank space works to make things easier to read. Awesome. So and if anybody has any questions, comments, or anything like that in the chat, feel free to drop those in the chat as we move into more data visualization with qualitative data. So qualitative data visualization is oftentimes a lot harder for folks. I can say even for myself, I have done a lot of report writing on the state health assessments, state health improvement plans. I've done report writing for strategic plans. And a lot of times when I'm doing data visualization prior to learning this or even not having time, my first thought is to go to, well, let's throw some quotes in that report. And I know we've all done that. And that's great for data visualization of qualitative data, but there are a lot of other things that we can do. So in qualitative researchers, and all of us as people who are doing assessments present open-ended data alongside quantitative results. We often have okay results showing a few quotes or word clouds, and that can reduce the value and depth of the information, and might not and don't show in creative ways how we can really highlight what's going on in the community and what we're hearing from primary data, what we're hearing from our community members. So these are a few principles that we can use to share our qualitative data in different and new ways. So the first here we have color and shape. Color and shape can be used to highlight commonality among respondents or topics. This might include visualization such as a heat map or a spectrum display. So this one you see out here on the left is from Mesa County, Colorado. It's their CHNA report. The link will be in the resources and the slides at the end. And their report is actually really cool if you're interested in seeing how it looks. But this is a visual heat map to show childcare deserts in their counties and in their zip codes. And the darker the orange zip codes, that indicates shortages. And that can also be used with qualitative data. Weight or size works really well. It shows the importance of information or hierarchy, so of findings. So word clouds are most commonly used version of weight or size. Oftentimes, as we see a word cloud, the words are bigger if they were said most often. So if people are saying what's the biggest health problem in their community, you do a word cloud, and most people said transportation, then that's what you're seeing. But that not always the most informative or valuable. So a packed bubble diagram like this can be used to highlight notable themes while also displaying a second dimension. So for example, this example is from a New York City anti-littering campaign where they asked respondents to look at a prompt related to a anti-littering campaign and share their reactions. So they were able to not only showcase what were people's reactions most frequently, which is the bigger bubbles that you're seeing. So do not litter, dispose of trash properly, things like that. But then you're also able to see their reaction. So it's two-dimensional. The colors also indicate was their reaction positive, negative, or neutral. And you're able to give more information there by showing this bubble graph. So that's one of my favorites. I think it's very cool personally. Next, we have gauge graphs. Gauge graphs are really, I think, also very cool. They break the mental model and tell a story. And gauge graphs are often used pretty frequently with a Likert scale or something like that to typically you would say, well, people strongly disagree or agree with this. And you see that in the data that you gather, and you're able to share this in a different way. So this is from a really great site called Evergreen that does a lot of data visualization work. And they're showing quotes, but then they're also showing on a gauge graph what people are saying, drugs and alcohol being unstructured, fostering no independence, and that level. So this chart it gives you the ability to visualize what people are saying in a way that we typically don't share with Likert models. And then we have proximity and connection. So this is used to highlight the interconnection of ideas, such as a process chart or a Venn diagram. This spectrum display also shows that. So it's a little small, and I recognize that, and I apologize for that. But the inner circle summarizes the broader category. So for this, the broader category in the inner circle is highlighting different thoughts of categories and diversities of opinion. And the outer circle summarizes any individual codes. So when you're doing your qualitative data coding, you have these overarching themes like safety and effectiveness and availability of something, and then the smaller codes are what you're hearing within that. They're getting at a more granular level. So they're talking about availability, but they're talking specifically about costs and prioritizing high risk. And so you're able to, within each circle, should read like a donut plot or a pie chart with the amount of space taken up by the slice of the donut, or pie reflecting the frequency that you're hearing that, which is why safety is much larger than, let's say, distrust. So these are a few ideas of ways that we can visualize qualitative data in a way that's new and refreshing outside of quote boxes and word clouds, which are typically what we use. Okay, I've run through data visualization pretty quickly, and we'll talk more about that. But we also wanted to note, think of ways as you're doing visualization, think of ways that you're sharing your data with your community. What are the best ways to connect with your community? You want to give them multiple access points to your information. What is the overall message that you're trying to share with them? What information do they need to know? Who makes up your audience? What are the characteristics of your community? What plans do you have to identify those folks and reach out to them? And what channels would work best? So those are things to consider as you are thinking about sharing your data. Okay, I'm pausing for questions, but I'm not seeing any, so I'll keep going. So wanted to share that and getting back to data visualization. That was a little out of order, but that is okay. We moved through it. So accessibility considerations. So accessibility is a big thing when you're doing data visualization because it helps us think beyond, how do we ensure that all of our data, what we're sharing, what are the biggest problems in the community? How do we ensure that that is accessible and inclusive for everyone who would like to see it or needs to see it? So some of the things that we consider with accessibility are color, labels and descriptions, and visual considerations for screen readers. So first we have color. So if we assume that at least one person that is viewing your data visualization has some form of visual impairment when it comes to color, there are some awesome resources that we can use to identify color vision deficiency and what we can use to ensure contrast. So even if there's some level of color vision deficiency, they can still see the difference between different charts. There's a really wonderful resource called Colors and Culture that also tells you what colors emote by culture. So a lot of times we're sending out specific things to communities, for refugee communities from different countries or different language speaking communities, and different colors evoke different emotions by culture. So that's a really good resource for folks who are interested in that. And then ensuring color contrast is important when you're reading or seeing a visual. Then we have labels and descriptions. So visual indicators such as patterns or shapes or charts and labels are really important for folks to be able to see it different. And so if that's like a dotted line versus a straight line, if that is different blockings of pattern or of shapes in a graph, like we've shown previously, those are really helpful for folks who might not be able to access just simply color differences. And alternative text. So you'll see in this when I send the slides as well, you'll see in this and everything we try to do and also find it very important to do is adding alt text or alternative text to graphs and charts and pictures and images and things like that. That provides additional context and explains more important details about the visualization for folks who can't see the visualization. Those are particularly helpful for folks who have screen readers. The alternative text picks up on those things, so it describes the image to them. And then final visual considerations. Size 14 font is typical for presentations as a bare minimum of size for folks to be able to visually see, and that's the most accessible at the minimum. And be conscious when you're using movement or animation or flashing as well. So here's some accessibility considerations. All of these links will be in the chat. They'll also be in the resource slides afterwards. Okay. And then finally, we have ethical considerations. So this quote I find really interesting. And the main part of it is that people who are doing this work, us as health departments and health nonprofits and all these people have a responsibility to find meaning beyond current understanding and bring inclusive light to answers, because inclusive answers are also the right answers statistically. So we have some ethical considerations of data visibility. So the first data visualization. So the first here is visibility. Are there hidden aspects of your data that should be brought to light? Think about a survey of human participants as an example. Are there marginalized voices that are not often represented but should be? Think about hidden labor, hidden impacts. Was there an uncertainty to your finding through negative results? That should be examined fully and closely for hidden narratives. Do you need, if you are finding that you're getting a survey sample of primary data collection from your community, and it is not highlighting the data, the health disparities that you're seeing in your quantitative data, you might have to ensure visibility by going back out into the community and getting those voices. Ensuring privacy. Present data that protects participants while maintaining their humanness and amplifying marginalized voices. We do this by encouraging small data. These are categories we often collapse to protect identities. So we need to think about new ways to present and visualize data that still honors anonymity. So one possible way is to ensure that there are common examples or pseudonyms or broadening geographic locations, depending on what that looks like. So we ensure privacy, but also share what's happening in specific subpopulations and communities. And the third principle is power. So consider the power you hold as the presenter of data and respond responsibly. So be an advocate for truthful data. Recognize that data, as it's being interpreted and visualized, can become obfuscated or subjective. So ensuring that as you are the person holding the power by creating these, paying attention to what your data is saying about your community. And then finally, considering transparency and how the data questions are developed, how the data is collected, and how the data is analyzed to build trust with your communities. Because ultimately, if you want to get great information, you want to know what's happening in your community, you need to build trust with your community. That's just some examples. The ethical takeaway is that data is not neutral, even quantitative data. It's not objective or free of bias. And because humans collect, analyze, and present data, that is why these tell a story, but it's not always the same. So we ask ourselves, what are we emphasizing? What values are we espousing? And what are we eliminating in the story we tell? So things to consider as you're visualizing data. And we have a lot more resources that talk a lot about this. And we'll share those out after this training as well. Okay, I've thrown a lot of information at you, and I'm seeing some chats. And when any questions are asked, we'll definitely come back to those. So we want to take a step back and think about specifically challenges with turning data into information. We shared a lot of information with you all today so far. And so we want to stop and see what your thoughts are. We want you to hear from each other and learn from each other. So we're going to open breakout groups. What we're going to do, and we're going to drop a link in the chat. Mediha, can you drop the note-taking doc? We're going to put you into breakout groups, and the person who should step up is the facilitator, is the person whose last name comes first in the alphabet. The person who will step up as the note taker is the person whose last name comes last in the alphabet. So we dropped a link in the chat that also has the instructions and the questions. So we have these two questions of what challenges do you experience? And we ask that you come back after a few minutes and share any ideas that you may have had or what conversations were sparked in these groups. And we'll give folks about 10 minutes in breakout groups. Does anyone have any questions before we get into breakout groups? Okay, hearing none. If anybody has any issues getting into the Google Doc, please let me know. So we're going to talk about what challenge you experience with analyzing and presenting secondary data and what challenges you experience with analyzing and presenting primary data. So we're going to go ahead and open the breakout groups now, and we'll give 10 minutes. Okay, I see a few people not joined. If you're having any issues getting into The breakout groups, please let us know. Okay.
Christy, did you need help getting into a breakout room?
Okay, okay. Hello, everyone. Looks like some groups are wrapping up. Folks are coming back to the small groups. We'll give everyone until the groups are officially closed, about 30 seconds to get back, and we're going to dive into storytelling with our last couple minutes. I'm not going to go too in depth, but we'll share out resources after this training. 19 seconds. Looks like some groups are really having some great conversations, so they haven't come back yet, which is exciting to see. So if any groups have anything they'd like to share in the chat, that would be awesome. what they learned from their teams. That would be their small groups. That would be really cool. Great. Well, welcome back, everybody. We're going to jump into storytelling with our time here left. If you have any thoughts that you'd like to share from your small breakout groups, feel free to drop those in the chat. This quote, I really just wanted to share this piece of this quote with data storytelling that is underlined, which is that data storytelling puts your data into context for and inspires action from your audience, which is a really big component of being able to do data storytelling. Some of the three main components of data storytelling, which we've already talked about the first two, data and visualization, wanted to bring this slide to show how all of these things work together. So visualizations are what we've already talked about to communicate your story clearly. And we've shared how data analysis works to understand the full picture of the health of your community. Finally, the narrative communicates the insights from the data with context. Let's mute. With context and action to drive your action planning and the implementation of your work. So there are 4 steps for data storytelling. The first is to tease the story from your data. Complete your analysis and step back and look at the data. What is your story? What is the story that your data is telling? The number 2 is the most important step. Know what you want to say about your data. What moves you? What surprises you? What's interesting? This point needs to be very clearly developed. The third is to know what about the data is most critical to your audience. Is that point at odds with what you think is important? Wow, words. And how will you reconcile these differences? And finally, sketch and storyboard your ideas for telling that data story. Use your hands, work fast, make a lot of mistakes, and enjoy that creative process. It's also a good time to experiment with charts and visualizations and things like that. Okay, so getting into narratives. I don't want to talk too long about that just due to time, but I want to share a little bit about narratives. So there's this really great resource, County Health Rankings and Roadmaps have been developing this called Narratives for Health. And it talks about how a narrative communicates and reinforces a worldview and engages people in considering their own understanding of the world around them. There are dominant narratives and transformative narratives. Privileged and powerful groups interested in maintaining inequities as the status quo and promoted a set of narratives that may harm communities by influencing worldviews and limiting change. That's a dominant narrative. In our field, it reinforces stereotypes and worldviews about health disparities in our community, about the health outcomes that we're seeing, and as a result, influences how we think we should address them. So it influences our action planning and our implementation, what strategies we develop. For all communities to thrive, we must build our own narrative power to transform what we think is possible and make necessary structural changes. So that's going back to the tree that we shared, the body that Aldara shared. And by doing this, we can ensure that health equity and justice become a reality. This is what we call a transformative narrative. Transformative narratives dismantle these stereotypes and worldviews by digging into and understanding / sharing the root causes of these disparities to understand the inequities that drive them. Transformative narratives help us better understand these root causes to be able to change how we address them in our action planning and beyond. So how do we shift from these dominant narratives to transformative narratives that can shift public consciousness to how our work in our community operate and how we can share any possible actionable strategies and solutions? A few things. So there are a few things that we can do here. And again, Narratives for Health and Madiha will drop that in the chat. This is a really great resource. This is very long. This is a very high level overview. Narratives for Health. How do we shift these dominant narratives? Identifying stereotypes, assumptions, and misunderstandings people already hold. Elevating new narratives through the data that we are collecting and how we interpret, and by getting both primary and secondary data, by understanding what's happening in the community and sharing them to allow our audiences to see a new perspective. And that audience could be anyone from our partners who are helping us create our IPLAN, our action plan, to our community at large, our public. Continue to uphold these new narratives and use them to build relationship and trust with your audiences, with your community, with your local public health system partners, and demonstrate these narratives through actions. It's not about winning an argument, but engaging people to explore beliefs and assumptions that they already hold. There's this really great relationship between narratives and messaging that we'll move past today, but if you're interested in it, this is part of Narratives for Health. And ultimately, the point of this is that we ultimately shift dominant narratives to transformative narratives that challenge belief systems through understanding the relationship between our messaging, the frames that we use, the narratives and ways that we communicate and reinforce the worldview, and the worldview, which is our varieties and beliefs, to drive transformative narratives through our actions. How we're communicating, what we want audiences to hear, the lens and the frame in which we bring some aspects of a picture into focus while distorting others, which points audience to a particular solution. And those are our actionable strategies, and how we challenge worldviews. So it's really interesting about this relationship between narratives and messaging. I kind of shared it, but not too deep. So how do we apply transformative narratives? So transformative narratives, like I said, are ultimately when you're taking a look at what you are sharing out with your community, the story that you are telling, does it reinforce stereotypes? Does it reinforce assumptions? Or does it bring to light root causes of inequities and the work that is actually being done to drive the change? So these are ways to apply transformative narratives in your work. You can do it through data evaluation and research, communication, policy advocacy, relationship and container building, and strategic and program planning. So we don't really have time to go through those right now, but I did want to share that. And these are all in the Narratives for Health link as well. So we are at the end of our time. I know we went a minute over, but thank you all so much. We want to share the evaluation poll. So if we can launch that now. For folks who are still on the call, please take 1 minute to respond to our evaluation so we can figure out how to improve each training for next time. So thank you so much. Take a minute to respond to that. And we'll keep that up as we also drop a link in the chat for the rest of our training series. So our next session is actually a group TA session with IDPH data stewards that'll be held on April 24th from 1 to 2 p.m. We're really excited to share that. We'll be talking about syndromic data, and we'll be talking about we'll be talking about syndromic data and another data source, and we're really excited to share that. And then in June, our next webinar will be June 26th from 1 to 3 p.m. And we'll be talking about building community power through policy and system change. And we'll bring back some of that narratives for health. So if you were hearing this and you were really interested in it, we'll talk a little bit about that in the next training. So thank you all so much. If you have any questions, feel free to message me. We'll stay on a minute. We dropped the link in the chat to register. If you've already registered, you're all good. But thank you all so much. I hope you have a great rest of your day. And thank you for joining us today. And we'll keep the evaluation up for folks who want to complete
I
it.
think my evaluation went off. I didn't hit submit.
Oh, okay.
I don't see it on the screen anymore.
If you clicked, did you click submit or?
No, I didn't. I was just
Okay,
trying.
it might be actually on the bottom of your screen in the Zoom. You might see something that says polls as one of the icons, and or there might be an ellipses that says more. Do you see anything?
Samantha, actually, I don't know how, but I think the Zoom poll ended.
Oh no. Okay, we should be able to relaunch it. Let me
Okay.
do that now. There we go. I'll read.
Oh, there you go. Thank you.
Yeah, thank you so much. I don't know how that happened. Thank you so much. We'll stay on so folks can complete the evaluation. Thank you all so much. And feel free to hop off when you're done.